Welcome back for today's lecture. Today is chapter 25 of our farm book. As you can see, we're going to be covering mostly antiarrhythmic agents and antiarrhythmic or antidysrhythmic drugs. We use those words interchangeably. Arrhythmia, dysrhythmia. This is not a class on learning how to read that. You probably won't get that until third or fourth semester. We will go over some of the basics. I want to understand the concepts underlying a lot of the problems. The big focus is going to be on the agents, the drugs, the medicines that we see in the acute care setting. And I'll let you know, I'll be specific. I bolded some things, put some things in red, focus on those. And I'll also let you know, closer to the end, there's a couple of slides that are key, so make sure you do follow to the end. As I'll drop some hints in there as well. So let's get going. We're looking at the heart today. We're looking at problems that are that a significant amount of people, both here in the United States and worldwide, have. The most common arrhythmia or dysrhythmia is atrial fibrillation. And there's quite a few different types of arrhythmias or dysrhythmia. So one thing to understand is, just like we know there's four parts to the heart, well, there's the left side of the heart, right side of the heart, then there's the upper part, which is the atrials, and the ventricles are at the bottom part. There's no difference in terms of the arrhythmias or the dysrhythmias. Some are going to be above the ventricles, supraventricular. Those are the ones that occur up in the atrial or the upper part of the heart. And then there are the ventricular rhythms that are happening in the lower part of the heart. And for the most part, the ventricular rhythms are slightly more dangerous. That said, atrial fibrillation, which is more of a, as the word says, atrial, up in the upper part, supraventricular tachycardia, those are the most common, and they have a lot of risks. Clots forming, people have to be put on blood thinners, and the problem with atrial fibrillation, again, even though it's an upper part, it's atrial that is fibrillating and not working well, electrically speaking, and as a muscle as well. Is that if we allow that heart, that supraventricular tachycardia, above the ventricle tachycardia, to go on long enough, it can go into what we call a RVR, or a rapid ventricular response. And once the ventricles start going pretty fast, then we could be in trouble, because we need to get that oxygen and slow the heart rate down and the rhythm, try to control that as best as we can. So the drugs that we're going to be looking at are a few key main things. We'll go into that today, but I do want to understand from a holistic perspective as well, what does this mean for dysrhythmias, and what type of conversation can we and should we, as both healthcare professionals and nurses, be having with our patients, and educating them as to the power that they have in their own hand, at least from a behavioral standpoint as well, to make decisions, determinations, change lifestyle in their own life. Antidysrhythmics or antiarrhythmics, again, same thing. Dysrhythmia or arrhythmia just means pretty much any deviation from the normal rhythm of the heart. And so the normal rhythm of the heart, we're not talking about here the heart rate, which is 60 to 100. We're talking about specifically the electrocardiogram, EKG, ECG. EKG is how the Germans called it, same thing. We call it ECG here. And so when you do an ECG, when you're in the hospital, a lot of patients will have to have, especially if they're having chest pain, rule out myocardial infarction or a heart attack, we'll put them on a 12 lead. Most patients on a telemetry floor will have to be on a 5 lead. When you bring the crash cart in, they'll be put on a 3 lead. So there's different ways to measure the electrical throughput that the heart is going through, leading to a lot of the arrhythmias. But basically, arrhythmia or dysrhythmia is just a very general term for any deviation from the PQRST, PQRST, PQRST. And in third and fourth semester, you'll learn how to measure the distances between the PR, the interval, the QT, so on and so forth. You will not be learning that here. Antidysrhythmics are used to treat and prevent the disturbances to this electric rhythm that's happening. There's a lot better ways than the drugs. When we're in the acute or critical care setting, there's nothing better than the drugs. But we do need to have a conversation once we stabilize them and we're getting ready to discharge them as to things that they can do. So we will cover both of them. This is an image that is showing the heart, and one of the key things here to know is that the electrical impulse starts from the SA node, sinoatrial, and moves through the heart, through the AV node, bundle of His, and down through to the Purkinje fibers. And at any point through this electrical system, there can be blockages, a lack of conduction, or there could be more than one spot of the heart that is triggering an electrical impulse. You want the SA node to be the main one. When there's more than one ectopy, more than one area triggering or shooting electrical impulses, that's not a good thing. That's pretty much what you need to understand right now. It's a lot more complex, and we'll get into some basics here for the most part. From a allopathic, downstream, acute, or critical care approach, we really are trying to just get that rhythm back to normal. Bottom line. And drugs work fantastically, but not only drugs. There's cardioversion, there's ablation, there's AV node ablation. We can do a atrial appendix closure. You can do a maze. There's a lot of different things that we can do to bring the heart back to normal rhythm. That's what you should know about the goal of this treatments that we're going to talk about today, is that we want to get the heart back to a normal rhythm. We can do it with drugs, which is what this class is about, this lecture, antiarrhythmic drugs, quinidine, there's a few. We're going to go over them. And some patients, especially the AFibers, atrial fibrillation, you'll hear me refer that as AFib, they need to be put on blood thinners because they're at a high risk for clots or strokes, clots dislodging, going to the heart or the brain. A major something to keep in the back of your mind throughout this entire lecture is that the normal resting state of your cell is in a negative electric charge. Now that gets a little more complex, and I'll talk about that when we get to the pump. But for now, keep in the back of your mind, for the cells to be resting, they have to be in that negative state. So negativity from an electrical perspective is the natural resting state of our cells. You want to keep that in mind, okay? We talk about action potential, and this is a neuron that is transmitting down through the myelin sheath. Remember in your physiology classes or prereqs to get into nursing school, the action potential carries an impulse. And when we talk about heart and we look at electrocardiogram, you do need to understand a little bit of the action potential, which is this move, this impulse of this electrical discharge through and down of the neuron to create, ultimately, we hope, in a positive state, a contraction of the heart, which is what we want to happen on a normal basis. Obviously, we wouldn't want to have a contraction that's tachycardic, because then that would be abnormal. So action potential, really, you want to understand that there's more potassium ions inside the cell than there are sodiums, and there's more sodium ions than there are outside the cell than there are potassium. And in this state, there's just not enough charge or charge difference to generate an electrical discharge. That's the resting state, when there's more potassium. Now, where it gets confusing is a lot of people say, oh, potassium is a negative. No, it's an ion. Potassium is positive, sodium is positive. Do not get confused here. Both potassium and sodium are positive. It's just that in the ratio that there are, there's more of the sodium perhaps outside than there are of the potassium inside. They're both positive, but because of that difference, of more sodiums than potassium, we say that the inside of the state, that the state of the cell within is in a negative state. It has more potassium inside the cell, but it has a lot more sodium outside of the cell, and because of that, the inside of the cell is said to be in a negative state, in a resting state, in a negative electrical charge. The nerve cells will send that electrical impulse telling your hands or your heart or your liver for whatever it is that it's sending that electrical impulse to do. It's telling them, it's communicating them, okay, now I want you to move your muscle in your hand, or telling the heart to contract. And so when you think of action potential, think of electrical impulse. And this electrical impulse, which you're going to hear me refer to as the action potential, really arises because of the concentration gradient between the ions. Magnesium is one of the very key ones as well, but the key players are two: potassium and sodium. Chloride plays a role, calcium plays a role, magnesium plays a role. We'll get into that, but right now think about potassium and sodium. So the cardiac cell, again, inside the resting cardiac cell, there's a net negative charge relative to the outside. And this difference in the electronegative charge results from that uneven distribution. As I was telling you earlier, there's more of the sodiums outside and fewer of the potassium. They're both positive. Therefore, we say that the resting membrane potential is negative within inside the cell. Hopefully that has become somewhat more, just keep that in the back of your mind. Don't worry too much about hyperpolarization. I want you to worry or focus, not worry, but focus on more on depolarization and repolarization. And one of the things to keep in mind here is that the main difference between the heart when it depolarizes and it repolarizes is that really depolarization is the loss of that natural state, that electrical state. They call it the loss of resting membrane potential because of the alteration of the polarization, right? Whereas the repolarization is nothing but the restoration back to the resting membrane potential after the depolarization. So again, sounds really complicated, but it's not that complicated. Think about it. Depolarization is that potassiums go out, sodiums come back in. There's a change. We go from a resting state, which the normal state, which is negative, it changes. The electrical impulse occurs, and then repolarization is to go back to the normal state of negativity within the cell. So repolarization, really, repolarization occurs not for an action to happen. Depolarization occurs for a contraction to happen. Depolarization occurs because you want the heart to contract. Repolarization occurs not because you want anything to occur, but simply because you want the heart to go back to its resting membrane potential. So how do cells control electrical currents? And this is going to be a big aspect that we're going to cover closer to the end. But basically the elements in your body, sodium, potassium, calcium, magnesium, they all have a specific electrical charge. And our cells are going to use these charged elements that we call ions or cations to generate electrical impulses. So we need to get these in our diet if we do, or we need to make sure that our potassium is not too high or too low, our magnesium is not too high or too low, our sodium is not too high or too low, our calcium, especially the free floating calcium, is not too high or too low. This shows the sodium potassium pumps, and it's extremely complicated. And basically, we have to have a pump that requires certain types of energy to maintain the uneven distribution of ions. We call it the sodium potassium ATP pump or ATPase pump. And so in contrast to depolarization, again, the process of repolarization it's not actively triggering any mechanical activity like depolarization is, which is muscular contraction, but it's bringing it back to a relaxation state. And so one thing to focus in on this image is that it's divided into four, right? You have a positive state on the outside, more of a negative state on the inside because there's fewer potassium. That changes with the action potential that starts bringing in sodium. Ultimately, in the third phase, potassium slowly starts to leak out. And then at the end, it tries to get back to its normal state of a resting membrane potential, okay? Again, action potential is the change in the ions. It's the movement of the ions across that pump to create an electrical impulse. And that's it. That's what we need to understand, is that the action potential or the electrical impulse is leading to a contraction of the myocardial muscle, and that contraction occurs thanks to initially the depolarization, and then repolarization is simply going back to the resting state, or resting membrane potential. So electricity is extremely important everywhere in our human body. Our cells are specialized to conduct electrical currents. Think about that. When we measure the EKG or the ECG, we're measuring millivolts. Millivolts. Okay, and we'll look at a chart about that later, right? And electricity is required for a lot of things. For our nervous system to send signals throughout the body to the brain, making it possible for us to move our muscles, for us to think, for us to feel. And what else do you think that we need to have proper ability of our body to produce electricity, ATP, right, within the mitochondria? What else do we need to have happening at the cellular level to heal? Our body needs electricity to heal as well. So not only to move, think, and feel, but to heal as well. And so one key thing when we do our head-to-toe assessment or we do a focused cardiac assessment, either way we're going to be assessing the heart. One of the things we want to look at is not only the rate of the heart. Is it 60 to 100? Is it below bradycardic, or is it tachycardic, above 100? We also want to look at the regularity. Is it regular or irregular? And regular just means that you have a really good drummer keeping a beat that's going like a 1, 2, 3, 4, 1, 2, 3, 4 beat. Basically, it's keeping if you're tapping on a table and it sounds like this, it's a very regular pulse. And so irregular means that at some point there may be a missed beat, such as, and then it goes back to a normal regular, and then it misses a couple beats and then it goes back. Or if they're constantly in an irregular, you just can't catch the beat. If you're a musician and you think of it from this perspective, basically it's slowing up and speeding down, slowing down, speeding up, slowing down, speeding up, and it's constantly changing. We call that irregularity. And people with atrial fibrillation will describe their heart as racing, pounding, skipping, flipping, irregular. So when we think irregular, when you put the stethoscope on the heart, you listen to the heart rate, you also want to be taking the peripheral pulses with your hand and seeing if there's a differentiation between what you hear at the heart, perhaps at the apex, point of maximal intensity, and you feel in the pulses as well. This will give you a good indication of whether it's irregular or not. Atrial fibrillation patients will literally, they'll say, I feel like I've been running a marathon 24 hours a day. I'm exhausted. I am exhausted. Their hearts are racing, difficulty breathing. Even when they're sleeping, they can't sleep because their heart is just constantly racing. Some people describe it as a fish that's flopping inside their chests. And one thing that as healthcare professionals we need to really understand is when somebody describes the ones, I'll go back to the previous slide, racing, pounding, skipping, flipping, irregular, or the fish flopping in their chest, we need to understand this is not a joke. AFib can really be completely debilitating to the patients. It can leave those who have the condition feeling completely drained of energy all day. And so we'll get into the energy and how we need the ATP and how at the mitochondrial level we can help to produce this. But when we're in the hospital setting, we need to learn a little bit more about the drugs first to try to get that heart back to where we want it to get. Because the last thing you want it to do is go into a ventricular tachycardia or torsades or something of that point. Again, these are just the normal ECG has a P, QRS, T interval. We're not going to go over that and learning how to look at, study it. These are the waves of a normal heart. P, QRS, T, P, QRS, T, P, QRS, T. And we know they're normal because we measure in between those little tiny boxes that you see, right? So horizontally, we're just measuring the length between a P or a Q or a QT or P, PR interval. See where it says PR interval, we're measuring it horizontally. That's just looking at the width or the time that it takes. And we know what the normal for a PR is. We know what a normal QT is. We know what the normals are. We're not going into that in this class. That's not the purpose. But guess what's happening vertically? Vertically, going up instead of horizontally. Vertically, we're measuring millivolts. We're measuring electricity. That's why knowing action potential, and that really the ECG is talking about an action potential, or the ability of the heart to make the heart contract and create these waves that we look at on this ECG, is extremely important to keep in the back of our mind. There are 4 phases of an action potential within a cardiac cell. It's important to know the phases mostly for the drugs, and I'll expect you to know more the 4 William Vaughn's phases than the phases of the action potential. Don't worry about the 4 phases at this point of the cardiac cell. Do worry a little bit more about what we'll talk about in a few slides from here. We'll get into that. What I would like you to really remember and understand is the concepts behind depolarization and repolarization. So I'm trying to keep this really simple here. What is depolarization? What is repolarization? And understand, and actually look at this chart right here at the bottom image. Horizontally, it's a impact that goes from a negative 70 up to a positive 30, back down to a resting state. Resting state is negative. Positive is or above 0 is when we get that depolarization to fire, and then repolarization is when it comes back down to a negative state. So look at what we're measuring on the left. We're measuring millivolts. We're measuring action potential. We're measuring electricity going through the neuron to stimulate a contraction. So know that the depolarization is that exchange of potassium sodium occurring so that it goes from a resting stage in a negative to a positive to create a cardiac contraction, muscle contraction, which is depolarization, and then it brings it back down through repolarization. That's what you really need to understand, the simple aspects of it. This is again going into the 4 phases. I kind of like this slide that I found for you because it shows you one of the first stages is when sodium starts to pour in, which is depolarization, and then the stage at which the second and the third stage is where potassium starts to leak, and then the 4th stage all the way at the end goes back to resting. So depolarization, calcium, potassium starts to leak a lot slower. The first thing, sodium comes in, calcium, potassium start to exchange, and then at the end we get back to the resting stage. And what is all of this about for us nurses? We need to understand that when we give certain medications, we're going to be working either to block the sodium or to block the calcium with the William Vaughn's. And you need to know what stages those are. So I'm repeating myself multiple times, and I've actually bolded it and put it in red as we go through. So I'm trying to be very specific here. And images help you see what's happening at the cell throughout what stage, and what stage the William Vaughn's that we'll get into shortly. You don't need to write that down now. It's very clearly indicated in the lectures we go through. You do not need to know this, but I want to plant a seed in your head because you will at some point in 3rd and 4th semester be exposed to learning how to read an ECG or an EKG. And remember, a normal EKG is PQRS, PQRS, PQRST, PQRST, I should be saying, right? And so one thing that we can look at when we do start to look at an EKG or an ECG is if you have somebody that has really high, for example, magnesium, hypermagnesium, we may get a prolonged PR or a wide QRS. Usually what we worry more about is low magnesium, hypomagnesemia. And I don't think I put the hypomagnesemia in here, but it would be similar almost to the potassium, a tall T wave or a depressed ST. Again, don't worry about this right now. You do not need to know this. Do not memorize this. Just understand that by looking at an ECG, we can determine by looking at the T wave or the U wave whether or not calcium, potassium, and magnesium is high or low. And you do not need to know this at this point. Just understand the concept that it is possible through looking at an ECG, which is an electrical impulse going through the heart thanks to an action potential and the contraction of the heart. Okay. Again, this is not a class of learning what the common dysrhythmias are either, because you'll get that in 3rd semester as well, maybe a little bit in this semester. But basically, we have supraventricular dysrhythmias or arrhythmias, we have ventricular, we have ectopy or ectopy foci, and we have conduction blocks. Okay, and the goal is to learn what drugs can help certain things. Ectopy or ectopic foci is basically, remember, the pacemaker. What's the pacemaker of the heart? I should have said that earlier. I apologize. The SA node is the pacemaker. And a pacemaker can be also a machine that we put in the person's chest to create a stable electrical impulse to help that person's heart stay within a normal range of heart rate, normal range of conductivity, so on and so forth. But the normal, natural body's or heart's pacemaker is the SA node. One pacemaker, there's multiple throughout, but the key one to initiate the heart's electrical impulse is the SA node. Ectopic foci is when you have abnormal pacemaker sites, more than one usually, outside of that SA node. And that creates automaticity, which is basically the heart starts firing and there's multiple nodes impulsing at once, which is not a good thing. And so keep that in mind. Supraventricular happen in the upper, above the ventricle, so in the atrial, and ventricular is in the ventricles as normal. This is perhaps the bread and butter of our lecture here. Do learn your von Willems classification. Do learn, because this is a very commonly used system that we use to talk about antidysrhythmic drugs. And it's based on the electrophysiological processes in the body. It's based on the 4 phases. So there's 4 of these that we need to look at. I found this chart or this image just to show you. There's basically 4: class 1, class 2, class 3, class 4. That's it. So class 1 is a sodium channel blocker. So when we go back to those images that show you when sodium comes in, well, we block that sodium coming in. Class 2 is a beta blocker. We'll get into that shortly. Class 3 is drugs that prolong the repolarization. Sodium right there, right? Sodium is the class 1. Class 4 then is the calcium channel blocker. And keep that in mind. And the image just shows you that class 1 is the sodium blocker, and class 4 is the calcium channel blocker. So it blocks that calcium from going back into the cell. And all of these are going to help bring, hopefully, the rhythm back to a normal. Let me take a quick sip here. Do not panic with this. Print it out, keep it out, use it when you're finally finished after your 3rd and 4th semester. We're right now in our 2nd semester. You do not need to know this chart. I just want to show you that arrhythmia can be treated through class 1. And what does class 1 say? Sodium blockers. What does class 2 say? Beta blockers. We can also use class 3, which are what? The potassium, right? And class 4, which is down at the bottom, are the calcium channel blockers. That you do need to know. Straightforward, right? Torsades, don't worry about it. The treatment for that is magnesium. Don't worry about right now supraventricular or AFib, but just know the 4 classes. And I also brought this chart for you to basically look at a couple of the drugs that each class has. You do need to start becoming familiar. Class 1, the only class that is broken down, so it does get a little bit complicated. Class 1, as we'll see here, is the only one that breaks down into A, B, and C. So let's go back to that chart here. Class 1A is quinidine, for example. Class 1B is lidocaine. Class 1C would be one of the flecainide, so on and so forth. So keep that in mind. Keep in mind that class 1 are the sodium blockers, but there's class 1A, class 1B, class 1C. And then also look at class 2. We have propranols, we have metoprolol, we have class 3, which we have amiodarone, which is a really important drug to be familiar with. In fact, it's what the American Heart Association uses for a lot of the dysrhythmias that are deadly. And then class 4 are the calcium channel blockers, and we have diltiazem, which is another important one to be familiar with. So what I went through and what I talked about this slide is what you really at this point need to be focusing in on, because we need to learn the concepts. This is just another thing that I put into the slide to show you that there's class 1, certain drugs, what actions they have, class 2, certain drugs, what action they have, class 3, certain drugs, what action they have, class 4, again, diltiazem's key one, black calcium channel blocker. You're starting to get the role here. So if I ask you, what does a class 1 do? You should be able to tell me, and you know the action. If I ask you, what does a class 4 do? You should be able to tell me, and you know what the action is. And you can read that. One blocks sodium, one blocks calcium. All right. Again, this is just showing you that the von Willems classification is divided into 4 classes, and class 1 is divided into 3. That's not clear in your mind, make sure it does get clear in your mind. So let me ask you, this is the type of thing that I want you to know in this class. So sodium channel blockers are considered what type, or what class, sorry, of antidysrhythmic drug? Is it a class 3? Is it a class 2? Is it a class 4? Or is it a class 1? Well, sodium channel blockers are a class 1. You need to know that. All right. Class 1, again, notice what's in red and bolded are the sodium channel blockers. Again, they're divided into 3. We've talked about that. We need to know what they're used for. They delay the repolarization and the action potential distance as well. And they're used for AFib, for PACs or premature atrial contractions, PVCs, VTAC. We can use these for ventricular tachycardia, which is one of the deadly ones, and WPW. If you hear me say WPW, it's because I don't like saying Wolff Parkinson-White syndrome. You do need to know that class 1A is used for what type of conditions. This is one of the examples that we have. One of the drugs, procainamide, we use again for atrial or ventricular tachydysrhythmias. Tachydysrhythmias, okay? Make sure you keep that in mind. Tachy, I should have highlighted and bolded that. I apologize, but know that. And there are significant side effects that we need to be very careful with. It can prolong the QT interval, flushing, rashes. It can create torsades, so they're not they're not a completely safe drug. And you need to know that we would not give it to obviously somebody who's allergic or has hypersensitivity, but anybody with the heart block. The heart blocks are the key ones that I want you to know right now, okay? Class 2, still in class 1 of the von Willems, phenytoin, for example. Phenytoin is one that we may need to know. It's given for seizures also. We may need to know what the blood serum of phenytoin is to see if the therapeutics levels have been achieved, or if we've gone beyond it, or if we haven't achieved that. So we'll talk about that shortly. But right now, we're talking still about class 1, but 1B. Remember, class 1 is divided into A, B, C. We just talked about one specific drug for 1A. Now we're talking about 1B. Lidocaine. You need to know that, again, we're in class 1, blocks what? Sodium. And lidocaine is used for ventricular dysrhythmias only. Lidocaine is used for ventricular dysrhythmias only. We use phenytoin for atrial and ventricular tachydysrhythmias that are caused oftentimes by taking digoxin or digitalis toxicity, which ends up in a long QT syndrome. And remember, when we say prolonged QT or long QT, we're talking about the ECG or the EKG on the horizontal. The QT interval, which has a specific measurement that you don't need to know right now, is going to be a little bit longer than normal. And if you're on a floor that is a telemetry or a cardiac floor, you will be using your calipers to measure the QT interval. Lidocaine raises the ventricular fibrillation threshold. So that just means that if we're going to have VFib at a lower rate and you give a medication, again, only for the ventricular, right? We want to raise the threshold so that it doesn't happen too soon or too early or at too low a threshold. By giving lidocaine, you're raising the threshold so that ventricular fibrillation won't happen until a higher threshold. So you're raising the ventricular fibrillation threshold with the goal of allowing it to happen at a later point, not too early or not too soon. Again, this is not it's a drug that has its side effects or adverse effects: twitching, convulsions, confusion, respiratory depression. We need to, or arrest. So we need to monitor their respiratory rate with this. Blood pressure could drop, heart rate could drop, and it could occur dysrhythmias, which is what the whole lecture is about. So we're giving lidocaine to treat a dysrhythmia, but it could cause a dysrhythmia. So we should have them on a monitor and make sure that we're keeping a good eye on them. We would not want to give it to anybody who has an SA or an atrioventricular block of any types, or anybody with the WPW syndrome. We would not give them the that class 1B. Class 1C, flecainide, is again a sodium channel blocker because it's a class 1. We use it for severe ventricular dysrhythmias. Can be used in AFib or flutter, can be used in WPW, can be used in supraventricular tachycardia, right? Mostly the tachycardias, but for the most part, you'll see it oftentimes used in a lot of the severe ventricular dysrhythmias. All right, so flecainide, that what we're still talking about, is a first line for AFib. It's commonly given for AFib, and it has a negative inotropic effect. You're not expected to know what that means right now, but I'm going to throw it in there for you because I think the concept is important to understand. We'll come right back to this slide. I threw this in so that you can understand what inotropy means, what chronotropy, dromotropy. Those are the three things that you need to slowly: inotropic, chronotropic, dromotropic. So inotropy works on the myocardial or the heart muscle contractility. Chronotropic is anything working on the heart rate, right? And dromotropic is anything working on the velocity of the conduction. So if I say it has a positive inotropic, it's impulsing that myocardial contractility. If I say it has a negative inotropic, it's decreasing the myocardial contractility. If I say somebody has a positive chronotropic, it's positive for the heart rate, increasing. If I say it has a negative, it slows it down. That's a negative chronotropic. If I say a positive dromotropic, it's increasing the conduction velocity. If I say a negative dromotropic, it's decreasing it. You do not need to know that right now. You will before you graduate. So keep this concept in the back of your mind because it is important. So flecainide, back to this class 1C. It's one of the key ones for AFib. It does have a negative inotropic. So what does negative inotropic mean? Let's go back to this. So if we know inotropic is working on any inotropic drug is working on a myocardial contractility, and this is saying that it has a negative inotropic, it's not necessarily working on the heart rate, which would be what? Chronotropic. It's not necessarily working on the dromotropic or the conduction velocity. It's working only on the inotropic. Otherwise, it would have said it has a negative inotropic but a positive chronotropic, or a negative inotropic and a positive dromotropic. A negative. Right now, all we need to understand is that it's having a negative inotropic effect, depressing or slowing down the myocardial contractility or depressing the left ventricular function. We want to get that atrial fibrillation in control. We want to bring it down. Generally, a lot of times you'll have AFib with the heart rate above 120. And so we want to give the heart rest. And one way we do it is we give this drug to depress that left ventricular function, which is that negative inotropic effect. If you gave a person that had atrial fibrillation a positive inotropic effect, you could be killing them. You don't want to give somebody with an AFib any drug that's a positive inotropic. Some of the adverse effects with this drug is dizziness, visual disturbances, dyspnea, so we need to ask them, Do not give this to anybody who's in cardiogenic shock. Do not give it to anybody with a second or third degree block. And do not give it to anybody who has a life-threatening dysrhythmia, like VTAC, for example. All right, we're now in class 2. We have two more to go after this one, all right? And class 2 are beta blockers. What do they block? They block the sympathetic or adrenergic nervous system. There are natural ways to do that. When we're in the hospital, we're not going to be doing it naturally. We're going to be doing it with a Vaughan Williams classification class 2 blocker, because it depresses the phase 4 of the depolarization. And we know that there's 4 phases, phase 1, 2, 3, and 4. Well, this one works on phase 4. And it's basically a general myocardial depressant for both the above ventricular, that's the atrial, supraventricular, think atrial, and the ventricular. So in the ECG terminology, again, the heart is divided into above and below, atrial, ventricles. When we refer in the telemetry or the cardiology world to non-ventricular or above ventricular or atrial, we call it supraventricular. So don't get confused. We like to confuse things, but supraventricular is happening above the ventricles in the atrials. And so we give this, we use class 2 beta blockers to depress both of the supraventricular and ventricular dysrhythmias. We can also use it for anti-anginals, as we've talked about. We've also used it for antihypertensive. Atenolol is one example of a beta blocker that we give, usually for beta 1. Remember, with beta 2, we have to watch out, because remember, two lungs. Giving something like this to a patient who has asthma or COPD can cause bronchoconstriction. And most of those patients need the exact opposite. They need bronchodilation, not bronchoconstriction. So make sure you don't give that to somebody who has a problem with lungs. We use it for antidysrhythmics, for hypertension. Don't give it to anybody who has severe bradycardia, second or third degree block, heart failure, cardiogenic shock, or some type of allergy to it. Class 3 is a good one to understand. Amiodarone is one of the key ones, sotalol as well, and it's working on phase 3 right now. Try to remember that amiodarone is a class 3 as the most important thing right now, and we use you'll see it given for VTAC or VFib or AFib or AFlutter that it is resistant to any of the other drugs. Then they'll be getting a lot of they'll be getting a class 3 or amiodarone. And again, it blocks the alpha, the beta adrenergic. It's one of the most effective antidysrhythmic drugs in the market for both supraventricular and ventricular dysrhythmias. And black and bolded there, I've noted that it's the drug of choice for ventricular dysrhythmia according to the ACLS guidelines. So if you've studied ACLS, which you will again and again and again, you now know that amiodarone is a class what? 3 of the Vaughan Williams classification. All right. We do need to know some of the adverse effects: photosensitivity, pulmonary toxicity, photophobia, visual halos. So we need to talk to the patients when we're giving them this drug. Say, hey, if you start having these visual halos, photophobia, let us know, or photosensitivity as well, and also monitor for their heart sounds. Drug interactions that this has. Digoxin comes from a plant. I forget what was the name of the plant. Foxglove, I think it was. And it's been used for more than 200 years as an herb. In the hospital, we don't use the herb. Outside of the hospital, I would be very cautious with using foxglove unless you know what you're doing or you work with somebody who knows what they're doing, an herbalist or a naturopathic physician, because it can be dangerous. Digoxin is a dangerous drug. And what the foxglove does, or what digoxin does, is it raises the intracellular calcium availability or concentration, which really increases that heart muscle, the contractions. So digoxin has a positive inotropic effects. It works more on the contractions, right? So and contraindications that we need to keep in mind. Again, and mostly if they're hypersensitive to it, then they're not going to get it. If they have an allergic reaction to it once, they're not going to get it again. but do not give with the amiodarone or this class 3 with sinus bradycardia, second or third degree heart blocks. Just don't. You need to know that, okay? All right. So if I were to ask you, again, I'm going back to the basics. We're still in our second semester here, so there's a lot to learn down the line. I'm trying to show you a lot, but bring you back to what you need to know. So if I ask you, calcium channel blockers are considered which type or which class, I should be saying, of antidysrhythmic drugs, and you should be telling me class 3 or class 2 or class 4 or class 1. And we know that calcium channel blockers are 4. Sodium would be the 1. Calcium is class 4 of this William Vaughn's. And the final one is class 4, which is what this question was asking about. Do you know what calcium channel blockers are? Class 4. So class 4, there you have it. Calcium channel blockers. So Von Williams classification, class 4, work as calcium channel blockers, mostly in the phase 4. We use them for PSVTs, paroxysmal supraventricular tachycardia, rate control, for AFib and flutter as well. So generally for a little bit of the faster heart rates. Diltiazem is also used a lot in the hospital for a rapid ventricular response. And remember, rapid ventricular response, you'll hear a lot of nurses talk to it about like RVR. And RVR is just, it tends to go hand in hand. It can happen outside of atrial fibrillation, but for the most part, you want to think of RVR as linked to atrial fibrillation or flutter or PSVT. So if your heart is fibrillating or fluttering or in tachycardia in a fast heart rate, 120, 130, 140, it can go really high. For the most part, when you're on the floor, a lot of patients may go into a tachycardia, and just for a minute, and then they come back down. We obviously want to keep our eyes on that. That's non-sustained. But if a heart goes into a sustained tachycardia, 1 minute, 2 minutes, 3 minutes, at some point the heart could go into failure, and you don't want that to happen. So if a patient is on AFib, and they're having, spikes of tachycardia, they're 101, 110, 19, 109, 98, 103, 110, back down to 97, back and forth. We got to keep an eye on them, right? Once they start going to 120, then back down to 110, and then back down to then up to 128, and then back down to 108, and then up to 118, and then back down to 107. Now we see that that range has changed, and they're still non-sustained. We just need to be a little bit more careful. But once they go into that sustained, I'm now in 132 and I'm not going down, we need to be very careful about that sustained fast heart rate, and we need to give them something to bring and reverse that rhythm down. One of the best drugs that we're going to give is diltiazem or cardizem. There are others, but this is one of the most common ones. Be careful with people that have an acute MI for multiple reasons, pulmonary congestion, Wolff-Parkinson-White syndrome, severe hypotension, don't give it, cardiogenic shock, don't give it, sick sinus syndrome, they're all over the area. They're bradycardia, tachycardia. We probably won't be giving them diltiazem to somebody like that. And somebody with a second or third degree block, don't give them diltiazem. So we just need to know that. But key is what's in red. And the drug name, what class it is, and what's in red, okay? Contraindications use of a lot of the antidysrhythmic drugs. Well, most of them, for the general, if they're allergic to it, don't give it. Usually blocks are a big no-no. A lot of the cardiogenic shocks are a big no-no, so keep that in mind. And ladies and gentlemen, the reason why I add in a lot more at the end of this lecture and go over a lot more is that once we can give them that diltiazem, we put them on a drip, we save their lives, we do CPR if need be, we give them a shock, bring the cash card in, do whatever. Now they're back out of the ICU, they're back down to the acute care floor, they're able to walk around. They're going to be going home on some type of antidysrhythmic. We need to have a significant deeper conversation with them about what is going on to lead them to have dysrhythmias and arrhythmias. And then we need to talk about the drugs. But I do want you to understand, this is not my slide. This is Elsevier's copyright 2018 slide. All antidysrhythmics can cause dysrhythmia. We need to talk to this to our patients. We need to be cautious. All antidysrhythmics can cause dysrhythmias. So I say it again. All antidysrhythmics can cause dysrhythmias. They can cause hypersensitivity reactions, nausea, vomiting, diarrhea, dizziness, headache, blurred vision, and prolong the QT interval. In fact, now that we're talking about COVID-19, what do you think the big problem with hydroxychloroquine and that zinc combination that everybody's talking about that works and that Trump talked about? Well, the risk with hydroxychloroquine is that it prolongs your QT interval. And so with people who have known cardiac problems, yes, it's a problem, but it's given to people who have conditions that as long as they don't have a cardiac problem, they can take it. There's not that big a problem, not that big of an effect. And so just know that prolonged QT interval. So some of the side effects that I'm going to take a quick sip here while you read this chart or this slide. Some of the side effects that both calcium channel blockers and beta blockers have, again, they're drugs that have risk. They can lead to congestive heart failure. They can produce lightheadedness and fatigue. You can have a fall and break a bone. You can have due to low blood pressure. They can lead to shortness to breath. Beta blockers that have that beta 2 can lead to further exacerbation of COPD, closing of the respiratory, and death, for example. And they can lead to bradycardia. So when we give these medications, we need to make sure that we in the hospital are doing a full set of vitals, but we educate them when they go home that they need to learn how to take their pulse and how to take their blood pressure. Guaranteed, okay? That we need to educate them how to do that. Drug interactions, generally speaking, if they're on Coumadin, we want to monitor their INR. You just need to know that. And grapefruit juice is a big no-no for amiodarone and for quinidine, and those are the two main ones. Don't worry about the third one that I have there. You need to know amiodarone is a big no-no for grape juice, okay? So here's so there are some unclassified. They're outside of the Von Williams. Adenosine is one of them. You'll see this a lot in the crash cart. You'll see it given in some of the emergent situations. What's in red, you need to know. If they're bradycardia and you give them this, you're going to kill them because adenosine slows the conduction, slows the action potential, That's what we want adenosine to do. So if they have already a slow bradycardic heart rate and you give them adenosine, you'll kill them. Don't do it. We use it to convert a fast PSVT back to normal or a sinus rhythm. Has a very short half-life. It's very important to know. And I'm going to ask you a question after this in a different slide, and that short half-life is going to explain why it's less than 10 seconds. Usually 2 seconds reverts, they come back to normal. And it's only given through a fast IV push. You guys got to know that. We give adenosine to slow conduction, usually for a PSVT to convert to sinus rhythm, and we give it fast. You need to know that. It's in red, it's bolded, I'm telling you, okay? And look at that, it may cause a systole, okay? Keep that in mind. Since it's in mind, answer this question. It's audience response time. Patient has received an IV dose of adenosine, and almost immediately the heart monitor shows a systole. They're dead, people, flatlined, a systole. Oh my God, what do we do? Check the patient's pulse. Prepare to give CPR because they're a systole. Get that defib machine in here. I mean, believe me, if you're giving adenosine, you have that crash cart and you already set them up. So you are monitoring them, right? But should we set them up for defib, right? Or do we continue to monitor the patient? Well, if you were paying attention to the previous slide, you'll know, oops, I thought I had an answer there. Sorry about that. You'll know that the half-life of the adenosine is really fast. What did we say, 10 seconds? And that the systole is only going to last, what did I say, 2-3 seconds? So we should basically continue to monitor the patient for any other side effects. So that's a normal thing. We just continue to monitor the patient. So when we give adenosine, we want to slow it. Sometimes in order to slow it, it stops it for a few seconds, then it kicks it back in. Hopefully it kicks it back into a normal sinus rhythm. Okay, that's an important slide to know. Nursing implications, we got to talk about what drugs they're on, what supplements they're on. They need to know what their blood pressure baseline is, cardiac rhythm. These are things that we're going to be monitoring at the bedside. We need to look at their input and output, urine specifically, because with low perfusion to the kidneys, the kidneys may start to go into failure. We do need to monitor much more than just the potassium level, but we do need to look at their potassium levels at all time before giving a lot of these medications. And magnesium plays a big role as well before we give potassium in ICU, not so much the floors. We need to assess for contraindications, drug interactions, grapefruit, right? And we need to instruct patients to report dosing schedules and adverse effects to the physician. They should keep track of how much they're taking and if they're having any reactions to it. We should obviously during therapy monitor their cardiac rhythm, heart rate, blood pressure, how they're tolerating it. Monitor perfusion, people, their skin color, temperature, pulses, warmth and cold sensation to the extremities, heart and lung sounds. We need to assess the plasma drug levels, and I won't be asking you to memorize the numbers of them, but again, this is kind of, I'm forewarning you for what you will need to know before you finish all 4 semesters. You'll get in the 3rd semester. Amiodarone, digoxin, usually, what were the other ones? Phenytoin, lidocaine, I think, is anti-dysrhythmic. I'm probably blanking out on one. We need to know that. And then we need to monitor for toxic effects. And one of the reasons we monitor plasma drug levels for these antiarrhythmias is precisely because if they go too higher and above, like digoxin, for example, they could be very toxic. And here we go. I added this in. You do not need to know that amiodarone needs to be between 0.5 and 2. And that above 2.5 is dangerous. You don't need to know that digoxin is critical above 2.5. Usually they're going to start having symptoms. Once they're about 1.5, they're going to start having some of those visual disturbances. But I want you to keep in the back of your mind, if somebody who's getting phenytoin, and it has to have that filter before we give them the IVs, and so on and so forth, phenytoin, for example, if they start going into above that therapeutic level, it could be as well. It could be toxic as well. You do not need to know the numbers. You need to know the concept, basically, back here, that we do need to, as nurses, assess plasma drug levels if indicated. A lot of times it'll be in the nursing orders, the doctor's orders. It'll be somewhere in the MAR, somewhere in the drug, if we have to give it. So just be aware that as nurses, a lot of these drugs, antiarrhythmic and dysrhythmics, do have plasma level that we need to check. And you will be expected in 3rd or 4th semester with Colin to learn these things right there. Further nursing implications, don't skip doses, don't double doses, right? Contact the physician if they missed a dose before taking anything. Tell them not to crush or chew any of the oral sustained preparations. And here's a question for you. So patient is receiving oral quinidine. Which assessment finding is of most concern? Quinidine, and I'm going to take a quick sip while you think of it. Is it nausea? Is it prolonged QT? Is it diarrhea? Or is it occasional palpitations? As I talked about earlier, you don't need to know what the normal distance when you measure with your calipers for a QT is. You do need to know that a lot of drugs can prolong the QT. Why do you need to know that? Well, simply because any prolonged QT, how do I put it? Prolonged QT is a precursor or comes before a serious dysrhythmia. So do you want your patient to go into a serious dysrhythmia? No. So a step before they have a serious dysrhythmia is they go from having a normal QT to a prolonged QT. That's why they're going to be on a telemetry floor. That's why they're going to be monitoring. So the answer to this question is if they're on quinidine or quite a few of the other drugs that we've talked about already that indicate a prolonged QT, just be aware of it and be careful. We need, again, monitor ECG, again, for multiple things, for the PR interval, if there's a block, QT interval, and if they're on an antidysrhythmic, because we want to make sure, amiodarone, quinidine, sotalol, all of these could be prolonged to QT. I believe flecainide, wasn't that one that we talked about? You should go back in this slide and I'll upload it as a PDF file to Canvas so you can look at it. But the slide, I think, of flecainide was one of them. You need to know that. And then we administer IV infusions. We got to get an IV pump. Solutions of lidocaine that have epinephrine should not be given IV. They're only used as local anesthetics. So you don't need to know that right now, but you do need to know about the QT and which of the drugs may prolong that. You need to know that. So when we give antiarrhythmias or antidysrhythmic drugs, remember that's what this whole lecture is about. That's what the chapter is about. We need to instruct the patient to, when they're going home, to notify, if you as a nurse, if they're your patient and they're in your bed, hey, look, if you do have shortness of breath, edema, dyspnea, dizziness, chest pain, GI, blurred vision, any halos of the visual changes or edema, again, we need to just notify me. Likewise, if we're sending them home and we're doing a patient discharge, they need to be informed that some of those dysrhythmias have pretty nasty side effects. We need to teach our patient that are taking beta blockers or digoxin or some of the other drugs how to take their own radial pulse for a full minute. We need to explain to them that the normal heart rate is between 60 and 100. We need to notify their physician before they take their next dose of a beta blocker or a digoxin, for example, if their pulse is less than 60. Sometimes the doctor will tell the patient if they've been critically ill for long periods of time, okay, you can hold it if your heart rate is below 55, but patients won't know any of this unless we tell them. So we need to tell them. That's part of the patient education that we have to do when they go home. We need to monitor for therapeutic responses. I give an antiarrhythmic. I give an antidysrhythmic. Right? And remember, people, when we as nurses do something, we want to assess before we do anything. When we do whatever we do, we want to assess after we do what we do. Let me say that again. We assess their heart rate, we assess their pulse, they're in a tachycardic rhythm, their difficulty breathing, their respiratory rate is fast, maybe it's very irregular, right? All of this leads to cardiac output is dropped, it's not good. So this is our pre-assessment. Oh my God, hey doc, or we go into the standing orders. Do we have anything to help with their dysrhythmia? Oh, it says, yeah, heart rate, if it goes above this, give amiodarone or give this or give that. Then we go ahead, we go into the room, we give it to them. We give it to them because we did an assessment that tells us, oh my God, or they're on a cardiac monitor that tells us they're in a sustained rhythm, not good. We had some type of assessment, whether it's your stethoscope, your hand on the pulse, the telemonitor that's telling you they're sustained. Whatever your assessment is, we do what we do. That's what this whole lecture is about. We give an antidysrhythmic. We give an antiarrhythmic. What do we always need to make sure we do after we did what we did? We need to assess to see if we need to evaluate the ADPI. The nursing process always has evaluation at the end of it. And the evaluation is, did their blood pressure improve? Did their edema go down? Do they feel less fatigued? How do we know that? Well, before they were only able to walk from the bed in the hospital to the bathroom door. Now they can go around the unit one time. Wow, that's a therapeutic response. That's a really good therapeutic response. Their pulse rate goes back to normal. If it was tachycardic and we gave something to bring it down, it's normal. If it was bradycardic and we gave something to bring it back up to normal, and it's normal, good responses. You get the point. So therapeutic response is very critical, very essential, very big part of our job as nurses. And now we're kind of stepping a little bit out, and there are some things that I do expect you to know here. But this is food for thought that I want us as healthcare providers to process, to think about. It doesn't mean that it's a guarantee or a proof, but it should allow us to think in a different way, and that will help hopefully our patients understand. So are all of these von Williams, amiodarons, class 1, class 2, class 3, class 4, etc. Are they? Is there anything else that science and evidence-based medicine can provide for our patients that have arrhythmias or dysrhythmias? What else? Let me put it this way: you're getting ready to discharge your patient, and you're going to talk to them. They're going home. They came in with some type of fibrillation. We managed to reverse it, did the right thing, and then we're sending them home. Yes, we need to talk to them about the drugs they're going to go home on, and we just did. You know quite a bit of information that you need to be giving your patient, but is there more to it? So let's think. Let's put some thought process. Your patient had arrhythmia. We've talked to them about going home on that drug, how to take their pulse, what to watch out, make sure they take their blood pressure, don't skip, so on and forth. We already went through all of that, right? What else can we educate the patient on? Well, the thing with a lot of the fibrillations, like atrial fib, for example, which is the most common one that a lot of the patients are going to be having, is to stop the trigger. Something is exciting the action potential. Something is triggering that. What is triggering that? Well, we don't know. The patient may not know. The cardiologist may not know. But we need to talk to them that sometimes it's very difficult to pinpoint what the trigger is or triggers. There can be more than one. So it's a big team effort that we, the nurses, nurse practitioners, doctors, hospitalists, intensivists, cardiologists, and outpatient primary care doctor, somebody at some point needs to talk to the patient that underlying that atrial fibrillation, there could be the sleep apnea, there could be obesity, heart failure, there could be vascular disease, there could be lipid problems, there could be smoking, inflammatory, hypertension, alcohol consumption, right? Well, let's keep looking at a little bit more. So with AFib, for example, or a lot of the arrhythmias and dysrhythmias, what are the triggers? There's a lot, people. Could be allergy to an environment or a food. If it's processed food, they may have contained something sulfite or nitrate, like all the processed meats. Caffeine, right? Alcohol, especially alcohol-induced magnesium, is a big one that we need to keep in mind. And so food additives, indigestion or GERD, if they're on a med that lowers their acid, right, levels, then are they able to digest the food, the nutrients, to get the potassium and the sodium and the nutrients like magnesium in? Over-the-counter medications, toxic foods, nutritionally deficient food, drug-induced nutritional deficiency, glutamate toxicity, electrolyte imbalance. In the hospital, electrolyte imbalance is really important, right? So we can talk to the patient that there are a lot of triggers: soap, toothpaste, glycemic levels. Wild swings in glycemic levels can produce. DKA can produce atrial fibrillation, right? So reducing general stress can help. Poor eating habits does not help. Sugar addiction does not help. Recent tooth work, root canal. If they work with turpentine, oil painting, brush cleaning, things of that nature. Overexertion, working out too much, dehydration. We don't know. So sometimes having a log to write down what's going on is really important because it helps trigger that. This is just repeating what I said earlier about caffeine, chocolate. Certain things are going to trigger it. Preservatives in food. That's why I always say don't eat processed foods, because something in the processed food that all it's doing is just making sure it has a longer shelf life. It may not be good for your heart. So eat a whole foods, plant-based diet with some meat in it, but relatively healthy meat. But bottom line with a lot of the arrhythmias and dysrhythmias, AFib especially, is that there's something that's exciting. At MSG, an allergic reaction, even some of the drugs. Remember what I said about the drugs. All antiarrhythmics can lead to arrhythmia, so go figure, right? Low vitamin D, low magnesium, some cheeses, like fermenting processes, can free a lot of the glutamates. One of the reasons why with meats, for example, why some people can eat closer to raw meat and not have a problem, and then they boil the meat, they have a beef stew with carrots in it and stews and whatnot, and then they get a reaction, is because they cooked the meat for long periods, which freed the glutamates, which sometimes fermenting does as well. So atrial fibrillation, arrhythmias, dysrhythmias, again, reactive oxygen species, aldosterone, right, causes increased level. of ROS. That's the oxidative stress. Atrial fibr is associated with an imbalance in ANS, or autonomic nervous system, right? We also, going back to the electrolyte, which is important for us nurses to know, low potassium levels is associated with PAC. So if a patient starts having premature atrial contractions, go check their potassium. They're also going to put them at risk for atrial fibrillation. And aldosterone is going to promote hypokalemia as well. So if they're having kidney problems and they're on one of those RAAS meds and drugs we've talked about, be careful. Low magnesium levels, right, is associated with increased PACs, which in turn could lead to atrial fibrillation. And guess what promotes low magnesium? Aldosterone as well. So we need to watch out with that. So parasympathetic and sympathetic, fight or flight or rest and digest, is a good thing I like to bring to the table because it helps us think in terms of our electrolytes. So what the sympathetic and the parasympathetic are part of the autonomic nervous system. One speeds up the heart rate, one slows it down. One we call fight or flight, one we call rest and digest, right? And we have the conscious and the unconscious, the autonomic nervous system broken down to two. I'm not going to go too much into this, but the unconscious nervous system is what we know as the autonomic nervous system. We don't have much control over it other than through the foods we put into our body, through the drugs we can give to reverse. I've seen patients on amiodarone go back into normal rhythms, and that's wonderful, right? But through diet, we can affect the sympathetic and the parasympathetic nervous system as well. So the SNS and the PNS, parasympathetic and the sympathetic, is a two neuron system, right, that affect the ganglion, and with the acetylcholine and all of that. But what I'm trying to get at here is the minerals play an extremely important role in sending the message through the action potential. For example, magnesium blocks the transmission between the two nerves and the ganglion, and it's one of the best ways to turn off sympathetic arousal. So when we wait for a patient to go into torsades before we give them magnesium, when we shouldn't. Magnesium should be given as an outpatient. We should be taking, many people are magnesium deficient. The problem with magnesium, again, is it gives a lot of people the loose stools, loose runs, especially if you take it orally or you take it in large dosages. So if you take it orally, don't take 500 or 600, take 200, right, at a time. Otherwise, you're going to have the runs. Or take it transdermally, put it through your skin as a 100% pure magnesium spray. You can do that. On the other hand, what does calcium do? It activates the sympathetic. Thank God for the Chinese and their yin and yang. We now know that magnesium blocks, right? It turns the sympathetic off, and calcium turns the sympathetic on. So it can help. If somebody's having tachycardia, right, you don't want to be giving, for example, anything that triggers the sympathetic. Exercise is going to lower the sympathetic system because it burns off sympathetic hormones, increasing the parasympathetic expression. Calcium and magnesium, again, regulate this system. This is what I was just talking about earlier, so I'm not going to go into this. You can read it if you want. But free excess calcium, again, it's the free calcium that will stimulate your... Calcium is not a bad thing if it's in the proper and the right place, in the bones and where we need it to be. And this relates significantly to people who have osteoporosis. And interestingly enough, a lot of time osteoporosis patients go hand in hand with having AFib, especially if you have a family history of someone who had osteoporosis or somebody who had AFib. Beware with osteoporosis and atrial fibrillation, and how you utilize magnesium and calcium. And how you learn how to do it. Make sure you work with the doctor who can help you know how to regulate that. One thing that's very important is that magnesium deficiency can clearly contribute to the development of potassium depletion, right? And in ICU, sometimes we have to give the ICU before we replace hypokalemia. If they're low in potassium, right, sometimes we need to give them magnesium before their potassium is replaced in order to get to give them the potassium supplement, IV or liquid or oral. That's the key thing that I want you to learn from this slide.
that a magnesium deficiency, which not all patients in hospitals have, but most of the ones now coming in with cardiac, slowly we're starting to look at that. So if your patient is having cardiac issue and rhythms, guess what they're going to check, people? Your magnesium. We shouldn't be waiting for them to be in a bed in the hospital to be your patient before we're checking the magnesium, really. Magnesium deficiency does what? It moves potassium out of the cell. That is bad news, Jose, if you're diabetic or a cardiovascular patient. Why? Let's go back to the action potential. We know the action potential, right, is a move between the two key ones for depolarization and repolarization, right, are potassium and sodium. Sodium comes in, then ultimately potassium goes out. So if you're magnesium deficient, you're going to constantly be having a trigger. You're going to constantly be in a positive state where we know that the resting cell membrane potential is what, people? Negative. Magnesium moves potassium, right? So magnesium deficiency is what moves potassium out of the cells. Having good amount of magnesium moves potassium back in, which is going to help the body go back to a resting membrane potential. Remember, depolarization does what? It creates that gradient change of sodium coming in to allow for what? What's the ultimate goal of depolarization? A cardiac contractility, a cardiac beat, right? Boom, there we go. We have it. Action potential, the depolarization leads to that. But we want to make sure that the heart can go back to its resting membrane potential. And the heart won't go back to its resting membrane potential unless it has magnesium. In fact, if you're magnesium deficient, you're going to be constantly keeping more potassium outside of the cell, not allowing the heart to go back to its resting membrane potential. So people, it's important that we look at the electrolytes, that we monitor them not only in the hospital, but in our own bodies, okay? Because within the context of electrolyte disturbances, it's important. I just threw this in there to show you that when you have low magnesium, which happens a lot with stress, more stress is going to happen because with low magnesium, your catecholamines. Remember, a lot of the drugs that we give that are antiarrhythmic, antidysrhythmic, especially which one, people? Which is the antiadrenergic, which blocks the sympathetic beta blocker, people. It's the beta blocker, right? So magnesium helps similarly as a beta blocker, because if it's low, it is going to release catecholamines, release free calcium, and then we end up giving them a calcium blocker because they had a low magnesium, perhaps, right? So once we get optimal magnesium, then that we don't need to be necessarily on a beta blocker or on a calcium if we have the proper amount. Obviously, if they're having a condition, we need to reverse stat. Although, in a lot of the emergent situations, you may be faced at some point, one of your patient goes into a weird rhythm. I've seen at least 3 of them in my career, and I had to give them magnesium, and it's called torsades. So if you think magnesium is not important, think again. Sympathetic. Let's not go over this. What I want you to know here is that magnesium inhibits the sympathetic nervous system output. Key thing. Magnesium inhibits sympathetic output, right? So does a lot of the other drugs that we try to give, like a beta blocker, the adrenergic. When you hear adrenergic, sympathetic, somewhat similar. So, is food bad? Is meat good? Is vegetable good? I don't like to think in those terms. I like to think that whatever you eat, whether it's vegetable or meat, that it's from a good source, that it's a whole food, has no antibiotics, no hormones, no nitrates, nitrites, nothing added to it, that it is coming in its pure form. And that's a lot better than anything else. But really, ultimately, when we eat our diet, it's really about balancing the calcium, the potassium, the magnesium, even the sodium. And the vegetarian diet, the plant-based diet for the most part, is full of potassium and magnesium, and they're very alkalinizing. And we know that our blood should be between what? 7.35 and 7.45. That's the basis. But is this true? Well, we do know that a vegetarian diet is fruits and vegetables, leafy greens, and it has these minerals, right? And we know that it's been shown in a lot of studies that magnesium suppresses sympathetic. So if you eat foods with and that potassium is thought to stimulate the parasympathetic. That's one other thing. I'm sorry, I forgot. I should have put that in here. But if magnesium lowers the sympathetic, but potassium increases the sympathetic, then people that are eating more of a leafy green vegetables, they're going to get more potassium. Now, obviously, if you have renal problem, you don't want to take or you're on dialysis, watch out with the potassium because that'll elevate too high, and we have to do dialysis earlier or sooner. I mean, with patients that are chronically ill or critically ill or acutely ill, it's a different role. For patients that are getting ready to walk out of the hospital and they're relatively healthy and they had a lone atrial fibrillation and we're sending them home, talking to them about minerals and the importance of minerals is extremely important. The acid base, let's think. So meat, yes, we know that meat is it's loaded with minerals like phosphorus and zinc, and they tend to have the opposite effect of a plant base, right? Like a high meat diet is going to stimulate mostly a sympathetic or downturn the parasympathetic. And imagine that, right? If your sympathetic is on and you're not in the rest and digest mode, how are you going to digest the most hard thing to digest, which is the meat, right? And our society, for the most part, tends to be more in a sympathetic, more in a acidic mode when we want our blood to be in a slightly more alkaline. So I'm going back here to the beta blocker just to remind you that when we have an overexpression of the adrenergic system, increasing the sympathetic activity, right, it can lead to an irregular heartbeat. That's no different, people, from having a low magnesium. Also, same thing, right? Or even a potassium, hypokalemia, same thing. Propranolol is the granddaddy, as we call it, for a lot of the arrhythmias and for hypertension and chest pain. But hopefully to your patient that's going out of the hospital, we can give something a little bit different. Calcium channel blocker was approved, I guess, back in the 80s for treating arrhythmias as well. We know we talked about it in our antihypertensive. And the heart is controlled, again, by the electrical impulse. What do we call that? Action potential, right? And not unlike a pacemaker, right? That sinoatrial SA node. Calcium plays a really important role in the heart's response to these electrical signals, this action potential. It flows between the heart cells and surrounding the fluid, right, through that calcium channel. And the more calcium that gets through before the electrical signal is received, then the more strongly the heart is going to contract. That's why we give calcium channel blockers. And guess which one is dark chocolate? 72%, 80%. Magnesium is a powerful calcium channel blocker. And unlike calcium channel blockers, for somebody who's going home, it is natural and non-toxic. Now, if they're on the calcium channel blocker, they should be explained that calcium, channel blockers, how they work, how they function, what they do, and that they need to work with their doctor carefully, right? And they can improve their diet as well. I always like to throw in Linus Pauling Institute from Oregon State University. This is a very long, it's a great article. Anything they put out is really good. And they talk about abnormal heart rhythm can lead to ineffective pumping of the heart, prolonged severe sudden cardiac death. And omega-3 fatty acids, the EPA and the DHA, have been shown not so much for arrhythmia, but they've been shown to prevent sudden cardiac death, or SCD. So nuts, right? Minimal amount of alcohol consumption for those who have already been consuming it is a safe thing. If they haven't been, don't tell them to go and start drinking alcohol. If they drink, too much, more 3, 4, 5 glasses or a 6-pack, they're drinking too much. A likelihood is that they'll be more acidic. They can go into a metabolic state. They could have an arrhythmia. They can go into metabolic syndrome X. They might be obese. They may smoke. On top of that, you get the problem. Consumption of coffee can trigger arrhythmias if you consume more than what's normal. And for some people, 1 or 2 cups a day is good. So people who drink coffee, they can stop for a while, see what happens, and then go from there. But if it's triggering their arrhythmia, remember, if they stop the trigger or learn what the trigger is, then they're going to be a lot better off down the line. and not need an ablation or anything like that. I just threw this in so that you could see the fish oil. By the way, for those of you who are vegan, there are plenty of ways to get your EPA and your DHA in a vegan diet, and that's very, very easy and possible to do. Supplement-wise, taurine, magnesium, great things, omega-3, CoQ10. If you're seeing a lot of repetitive things for coronary artery disease or congestive heart failure or MIs, it's because the mitochondria don't distinguish between the diagnosis and what you call it, what we call it. It's an MI, it's a CHF, it's a CAD, it's a CHD. The mitochondria really function to produce ATP properly and allow things to happen. So one thing that I found really interesting, and we're almost done here, I believe, is that I want you to start thinking about this. Again, this is just food for thought, nothing else, people. Right? Don't criticize anybody who wants to expand your and broaden your way of thinking as a healthcare professional. Right? There are a lot of there's a lot of evidence out there that we ignore because we're just not trying to broaden our understanding. So I want to broaden your thought process here. pH means what? Acid or base. pH means power of hydrogen, correct? Hydrogen, I believe, is a positive charge. It's a voltage. It's in liquid. When we measure the EKG or the ECG, what are we measuring on the vertical? We're measuring millivolts. Millivolts might be related to pH. Just a thought. So the amount of oxygen in the cells, it is believed, Jerry Tennant wrote this book. He's very poo-pooed by allopathic, and he's on the quack watch, and he's on that. I don't know if what he's saying is true. I find what he's saying is fascinating. I think what's even more interesting is that as soon as somebody comes out with a theory, big guns start pointing at them saying, oh, quack, 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 he's dangerous. No, as healthcare providers, we don't need to jump on the bandwagon and say, oh, he's absolutely right. But what science, what we want to do is keep an open mind and say, well, why not? Is it a possibility? We don't know, but think about this, all right? The amount of oxygen in a cell is determined by a voltage, okay? There's three main actions. So how do we produce electricity? We're back to the EKG. Remember, we're talking about arrhythmias and dysrhythmias. Well, let's move a little bit down to the cellular level now, because the heart that I showed you, that big, nice tissue, that muscle, there's more to it. Well, what's to it? Well, let's get into it. There's a lipid substrate, there's a pH differential, there's raw materials that we need. We've been talking about the raw materials all along, people. If you don't have the raw materials, right, in the proper way, to just work with the provider who's going to understand how these work and function and what ratio you need to have them in, right? So electricity will not be made properly. That means an action potential will not be made properly, or you will have an excessive excitation of the heart because you have a lack of raw materials. You may go into an atrial fibrillation, end up having an RVR, end up having an MI, and so on and so forth, if your body is not producing electricity in the proper way. And I throw this in there so that you can take a quick little look, right? The human's body pH level is really a direct reflection of its voltage. A low pH is what? High acid. Could mean a low voltage. A high pH, which is what? Alkaline, could mean high voltage, right? So if a cellular voltage is low, the amount of oxygen in the tissue could be low, right? This is just a could be. Remember when we look at that QPRS, that PQRST, the vertical axis is millivolts, right? Now look at the image on the right. You do not need to know how to interpret these leads, but I'm telling you right now, in all of these leads, especially V4, V2, V3, but even in V1, V5, and V6, what do we see? ST elevation. You've heard ST elevation many times, and what is a STEMI? You guys don't need to know how to interpret this yet, but you need to know what STEMI means. STEMI is a ST elevation myocardial infarction. And that image you see right there is called a tombstone. Somebody gets a tombstone, right, in their V2. Look at their V2. It looks like a tombstone. That's pretty much, they probably have a 100% blockage, and if they're not dead yet, they're on the way to be there if they don't reverse that pretty quickly. This is the epitome of downstream medicine. And in downstream medicine, we can do wonderful things. And many people that end up having that tombstone can be reversed. Many of them can't. And those who work in ICU and ED will attest to that. And you nurses moving into these areas will eventually attest to that. Right? So think about that. So let's get back in. So pay close attention to what we're saying here. When you look at those squares and you pull out your calipers and you work on a telemetry floor, you're going to be measuring the amplitude, right? And then you're going to be measuring the width, right? And so if the resting potential of a cell is in the -60, -70 before the depolarization happens and then the repolarization happens, right? Remember repolarization and depolarization? Depolarization triggers contraction. Repolarization just goes back to a normal resting potential, membrane potential, and that tends to be negative. So let's think about this, people. I want you to take a step a little bit forward, and we're gonna think about necrosis in just a second. I thought I had a different slide here, but let's think about this right here. Actually, I'm not going to go into this. So one thing I will point out here, every part of the body has a different pH. And if you think at any point that people selling you alkaline water or trying to alkalize your blood with fluids and liquids, think again. The blood is in a natural homeostasis, and through buffers, which we'll talk about in a second, is going to keep the pH pretty much within 7.35 and 7.45. That doesn't mean that eating an alkaline diet is not good. It just means we're not eating an alkaline diet to alkalinize your blood. But if you have a gastric secretion, which should be between 1 and 2 or 1 and 3, right? See the pH of your gastric of your stomach, and you're on an antacid, and now your pH is more alkaline. It's at a 5. The likelihood of you being able to absorb and digest, which we've talked a lot about in our classes, is very null. So you can eat a whole food, plant-based, organic diet from Whole Foods stores and still not be able to digest anything. So probably your voltage won't be, your pH won't be in the proper order, and your oxygenation level is going to be changing. So just a quick review here, and I think we're getting ready to wrap up here shortly. Let me ask you, which cells contain the largest amount of mitochondria, and which organs contain the most mitochondria in the body? Which cells contain the largest amount of mitochondria are fat and muscle cells, like the heart. So which organ do you think contained the most amount of mitochondria in the body? Can you guess? You guessed it. One of them was the heart. Absolutely. Absolutely. So let's get into the point that I wanted to talk about here briefly. We have a healthy cell and we have an unhealthy cell. We know what leads to the 3 finite insults of inflammation, oxidative stress, autoimmune response can lead to a heart that has many mitochondria, but that don't function well to produce the ATP, creating a proper action potential and creating ultimately necrosis. So keep this necrosis in mind. I want you to keep this in mind. We're getting somewhere here, okay? This image here just shows you what a functional mitochondria should be. ATP is producing energy, the action potential is working well, and where, people, is the resting membrane potential going to be? In its negative state, slightly more alkaline state, okay? Dysfunctional, that's where necrosis starts to happen, is where cell death occurs. Okay, we're getting here, necrosis, okay? One of the reasons, and as healthcare professionals, I would highly suggest you follow Bruce Ames. He's out of Children's Hospital Oakland Research Institute, CHORI. He has thousands of articles that he's published, and he came up with the notion that inadequate dietary intakes of vitamins and minerals, right, most likely due to the excessive consumption of energy-rich or micronutrient poor refined food, right? So inadequate intakes of these things are what ultimately lead to chronic metabolic disruption, including mitochondrial decay. So when I go back to talk about that blood, why drinking alkaline water will not alkalinize your blood, is because The blood pH should be between 7.35 and 7.45. It's very hard to change that. Remember our lecture about the kidneys and the lungs and the pH? We do an arterial blood gas. Most of your patients in the hospital that end up having a lot of these arrhythmias and dysrhythmias are going to need an arterial blood gas. In fact, you know that that's one of the ways that we assess for a lot of the complications. What do the kidneys produce? What substance that's alkaline? Bicarb. What substance do the lungs work with that we need to try to eliminate from our body through oxygenation, gas exchange? CO2, that's an acid, right? So let's get into this image right here. I want you to think about this. A lot of these patients that you see that have necrotic tissue are having necrotic tissue. Let's go back to this right here. You may think there's no reason or no purpose for what I'm trying to say, but if a patient has and tries to keep their blood level constantly between 7.35 and 7.45, it's doing it because it's consuming up, right? It's utilizing up a lot of the nutrients that the body already doesn't have. Let me tell you, a patient who is this patient that's sitting there in front of you that has that amputation in that image or that necrotic tissue? Who is this patient? It's your metabolic syndrome X, correct? It's your diabetic patient. What do they have? Hypothyroid usually, right? Adrenals, hypertension. They could go into DKA. They could go into and when they go into sepsis, what do we look at? We look at for their lactic and the lactic acid. So if you think there's no rhyme and rhythm to all of this that I'm talking about, I'm trying to get you to really think that there absolutely is. That necrotic tissue is happening because there's not enough oxygen there. We look for their pulses, and we have to put a little X on their foot. Probably why? Because manually we can't palpate it. How do we detect that? Well, we go in and we just check it. God, why am I blanking on it? Pulse ox, well, not the pulse ox. Anyways, I'll get back to it. But basically, if you were to manually check that palpate with your fingers, you wouldn't have any pulse to that area. The tissue is necrotic. What sign and symptom might a lot of these patients going into DKA, metabolic syndrome X, acidosis, high lactate, what breathing symptom might they have? You remember from our previous lecture, Kussmaul breathing. And what is Kussmaul? Dr. Kussmaul, I think I have it in this lecture right here. Let me go down to here. I have it in one of these lectures. We'll get into that. It's air hunger, people. Kussmaul's discovered that all these patients that breathing was air hunger. If they're breathing like that to get rid of the CO2 and to try to rebalance off the pH in the body properly and control those ABGs, if their body's already breathing through Kussmaul's, no wonder their toe looks like that, right? They're low oxygen, late stage nutrient insufficiency due to prolonged improper lifestyle choices, high processed foods, high sugars, high trans fats. So in the hospital, we're dealing with the right side of this. We're dealing with, CRP is a lab that we can test before they end up having a problem like we saw previously. I'm talking about talking to our patients once we have them stable and they're walking out. I'm talking about midstream, not necessarily upstream is policy change, but changes in smoking, nutrition, physical activities, other things like that. In the hospital, we're dealing with disease, injury, infection, chronic problems, acute and critical care problems. So, all right, to finish up, we do need to talk and think about our patients that are going into arrhythmia, apart from the Von Williams and all of those 4 classifications, right? We need to know that electrons can be obtained from many sources. Unprocessed foods, green leafy vegetables, structured water, sunshine, working, standing in soil, music, fresh air, wind, exercise. You get the point? What else can we do to change that pH and that proper voltage? Remember, pH and voltage, we should be thinking oxygenation, right? Walk barefoot on the earth, grounding, spend time in nature, drink water from a moving body or structured water, properly filtered water, right? Eat food grown from the earth in its natural state. You get the point, right? Other interventions, there's a few more slides here, is how do we restore cellular energetic processes? Remember, mitochondria, when you look at that necrotic tissue, something's been happening there for a long time. We need to make sure that our patient, that all they came in for was an AFib or one stent, and they're going home relatively stable, maybe on one or two meds, is that if they want to prevent coming back in and end up, especially if they're diabetic, end up getting an amputation, that we can provide nutrient support. We can help them with enhancing their detoxification and providing proper production for ATP and metabolism. Because when we're not doing this, we end up as that patient that we just saw in that image with necrotic tissue, right? So if you have a tissue that's necrotic, then the likelihood of healing with any medication you give it, you can save their life, but if we don't have this conversation, it's just not going to happen. And we're done. There are these last three things for anybody who, I'm presenting this report, afibbers.org. It's a great resource. People who have atrial fibrillation go on there, write their comments, ask questions. There are hundreds of great documents. This is one 12-step plan for AFib elimination, and I think there's these 2 points. There's up to 0.5. 0.5 is talking about your magnesium, potassium, and the taurine, for example, right? And then the last 6 through 12 talk a little bit about what else is going on in your body, what we can talk about. Beta blocker, consider going on an antidysrhythmic rhythmic full time. Flecainide, right? Flecainide, what does flecainide do to you? Flecainide prolongs your Qt, right? That's one thing that you guys need to know. And so we can move in. Drugs play completely play a role, but so do talking about oxygenation as well. So we need to think about arrhythmia and dysrhythmia and our approach to drugs from multiple levels. When you're in the hospital, we need to consider the electrolytes and the von Williams class 1, 2, 3, and 4, maybe adenosine as well. We need to make sure we know how to monitor the right things, cardiac monitoring, BP, vital signs, and so forth. But we need to bring our mind down to the level of what's going on at that, so that person that had that necrotic tissue in the toe, when somebody's having an MI, how different is the MI, that part of the heart that's becoming dead tissue, necrotic, that's not receiving the blood, which has oxygen and nutrients? How different is that necrotic tissue in the heart from that necrotic toe? Can you guys answer that question? You should. That necrotic tissue to the toe is absolutely no different than the necrotic tissue that's happening on the heart. Absolutely no different. There's just not enough oxygen. That resting membrane potential, which is constantly at a negative, is not being allowed to happen. And there's many ways we can approach this problem. As healthcare providers and evidence-based providers, we need to instruct and inform our patients about the drugs that they're on, about the options that they have, and about looking to work always with the primary care provider that knows how to work with their electrolytes and nutrition and lifestyle as well. It's absolutely essential. So that said, hopefully you enjoyed, and go back and focus on those von Williams 4 classes and the things that are bolded and in red, and you'll be good to go. So have a rest of the good weekend if you're listening to it on the weekend.